Good afternoon. I'm one of the quality coaches at CMHA Ontario with the E-QIP team, and very pleased to welcome our guest speakers today for our second part of the series, Better Data, Better Outcomes, a data literacy series on using data from standardized tools. We will start today with a land acknowledgement as a way to respond to one of the many calls to action in the Truth and Reconciliation Commission report. Starting our meeting this way encourages us to remember the historical and ongoing impact of colonization of Indigenous people as we make decisions on behalf of our organizations that will impact the people accessing our services, so that our decisions may always move us in our work towards reconciliation and healing relationships with Indigenous nations, people, and the land. As this meeting's occurring in a virtual space and participants are coming from across the province, I'll start by locating myself and acknowledging the land that I'm joining from. I am a white cisgendered male and a settler of European descent. My family settled here from France and Germany and Ireland between the 16 and 1800s. For the past 15 years of my life, I have lived and worked in the Niagara region. Today, I'm joining from Welland, Ontario, and I acknowledge the land on which I gather is the traditional territory of the Haudenosaunee and the Anishinaabe people, many whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging reminds us of our great standard of living is directly related to the resources and friendship of Indigenous people. I will end today by encouraging all of you to take some time to reflect about the colonial history of the land you are joining from. And if you don't know, to take some time to learn about it today. Next slide, please. As we get started, just a quick housekeeping item. We've got lots of information for you today about the OCAN, and just encouraging everyone to kind of put their settings on mute. And we do have space for questions, and we'll be using the chat box as well. So data literacy. So this today's webinar is part of our data literacy series, focusing on standardized assessment tools and data in the community and mental health and addiction sector. Today's focus is focusing on the OCAN. You can go to the next slide, please. And so today we're going to focus on what the OCAN is and why we use it, and then also an overview and examples providing of how we can analyze and use the data to inform service delivery and decision making. Next slide, please.
Sorry, there seems to be a delay in my control of the slides.
That's okay.
There we go.
And E-QIP offered a data literacy series in 2020 that we want to reference that answers the following questions. So if you didn't get a chance to review that back in 2020, the recording of these webinars are available for your review. And that will be included, the link will be included in the slide deck we provide after today's webinar. Next slide, please. So data literacy and OCAN. So data literacy is the ability to collect, manage, evaluate, and apply data in a critical manner. And our guest speakers today are going to focus on how we can use OCAN, what does it tell us, and how can we use it to evaluate our population we serve, and how we can apply it to decision-making and services we provide. Next slide, please. Which brings me to, we have a lot of examples to provide with you today. So we're putting this up front that if you do have questions, given this is a two-part series, and February 2nd, we have our 2-hour workshop, please write down your questions and put them into the chat. Our focus is if we can't answer them today, we will have some time at the end of today's session to do so, but we will bring those questions with us to our workshop on February 2nd and give you an opportunity to have those questions answered with your own data. So please do put it in the chat. Laura and I We'll be monitoring that and ensuring that we can provide responses to you. And in addition, if you're unable to make February 2nd, we will be drafting a question and answer sheet. So we will make sure that your questions get answered. I get the pleasure of introducing our two subject matter experts and speakers today, Jennifer Zosky and Frank Sorocic. Jennifer is a social worker. Her position is a clinical assessment specialist at Ontario Health. She supports the child and youth and adult mental health sector's use of evidence-based standardized assessments. Jennifer has worked in direct service, management, and system level roles in the community and mental health addiction sector for over 30 years. Frank is the Director of Data Analytics, Research and Evaluation at the Canadian Mental Health Association Toronto branch and is the Assistant Professor at the Faculty of Social Work at the University of Toronto. He has over 20 years of experience working in the community and mental health sector in clinical research and senior leadership roles. I'm going to pass it over to Jennifer to start talking about the OCAN.
Thank you, Ian. And I'm going to the next slide. Here we go. Naveen, thank you. For some reason, there seems to be a bit of a delay. So if we have a problem, I might give you control back, but let's give it a try. Hi all, thank you for taking the time to attend today's session. Before we start, I do want to prepare you that you're going to hear quite a lot of information and that can feel overwhelming. It's kind of like drinking from a fire hose today. So to set expectations, today we're covering some general principles and examples of how OCAN data can be used from client through to provincial levels. And as Ian said, on February 2nd, there'll be a lot more opportunity really to dive into more detail in an interactive way. So to level set for everyone here, let's start with what is OCAN and why use the data. This may be repetitive for a lot of you, but hopefully it's good reminders that will be helpful when looking at when we start to understand and interpret the data. Now it's going fast for me. There we go. So there are a number of key questions the community mental health sector is not able to answer. And these include who is using CMH services, which services, for how long, what care needs do people we serve have, what are service outcomes? So are services having a positive impact on people being served? And do outcomes differ across groups? So from a health equity lens, are there disparities?
Programs will tell you quite easily.
Maybe if we could, I'm just going to pause for a second if everybody could put themselves on mute. Thanks. So the last one is, do outcome differs across groups? Do outcomes differ? And from a health equity lens, are there disparities between different groups? So throughout the presentation today, we will talk about the data in the context of helping to answer these questions. So OCAN data can help to begin to answer these questions, and we're going to take a look at the components of OCAN connected to the questions. These are the components of OCAN, and the ones at the top two are the consumer self-assessment or client self-assessment and staff assessment. And they assess the needs of service users and can help answer the question, what are clients' needs and strengths? And doing this assessment at regular intervals while a person's in service can help answer what are service outcomes? Are services helping to address needs over time? And that part of the OCAN comes from the Camberwell Assessment of Need, which is an evidence-based instrument selected by the sector and includes the perspective of the client. In the middle section, the Consumer Information Summary, that provides socio-demographic information such as ethnicity and outcome, and can help answer the questions, who do we serve, as well as how do outcomes differ across groups. And then finally, the Mental Health Functional Center Use section helps to answer the question, where do you receive services? What type of services, such as case management? So why use this data? How can services use it for quality improvement? We'll describe specific examples through today's session. Here's a list, though, of some key points. So OCAN data can identify areas where services are addressing needs, so those strengths, and validating the hard work of dedicated staff, as well as identifying areas where there may be gaps. And OCAN data can help to be used to help measure performance, where services are helping to improve client outcomes. And in areas where you're falling short, using QI methodology to develop and test change ideas. And some of those change ideas to better address needs could be new programs or modifying existing programs, focusing staff education on evidence-based interventions, outreach to specific equity deserving groups, linking clients with partner organizations within an OHT, for example, and advocacy activities. Here's a little bit more detail about OCAN, the last slide about OCAN, and this is a postcard that some organizations are giving to service users to describe the process and some key content of OCAN. So this first side of the postcard shows an overview of the process to support a person's recovery. When you enter service, OCAN is the assessment used to help identify your strengths and needs. And this information is used to create a recovery or service plan. And every 6 months, a review is done using an OCAN reassessment to identify progress, needs, and make changes to your recovery plan. And the second side of the postcard provides some more detail about the OCAN. Here are the 24 domains that OCAN cover. And you can see it's a wide range of basic needs, health, social, and functional areas. And for each of these domains, needs are identified by selecting one of the following options. No need, so that area is not a problem for the person. Met need, that's not a serious problem because help is being provided, so support is being provided. And those two ratings for a domain can be seen as a client's strengths, things are going well. Unmet need is those are the areas to focus services on because those are the areas where there is a serious problem for the person. And of course, for every domain, there's an option to select I don't want to answer. Went too far, sorry, there we go. So before we talk about the data, just a little bit about where OCAN is supported. So within Ontario Health, where I work, there's a team that supports the collection and use of assessments in various sectors. And it's called the Standardized Community Assessment, SCA, and the Integrated Assessment Record, IAR team. The team helps to maintain standards, provide education on coding and clinical use of a number of evidence-based assessments, OCAN being one of them. And we also support the use of OCAN data. We help organizations to implement assessments as well as to implement the IAR. And I'll just show you information about the IAR. It's a central repository that contains data from multiple community sectors. And the picture there in the middle shows the sectors and the names of the assessments. And the orange box is around what we're talking about today, the OCAN. Clinicians can view consented assessments completed by other providers in their client's circle of care to help coordinate care. And also the IAR enables secondary use of the data for quality improvement and planning. So for organizations that are uploading OCANs to the IAR, they have the ability to access aggregate OCAN reports. There are approximately 9 million assessments in the IAR, reflecting almost 2 million unique clients. So a little bit of the lay of the land of what OCAN data is available to you. There are 3 sources of OCAN data that can be leveraged for planning and performance measurement. The first is OCAN data within your own organization's software system. The second are OCAN reports in the IAR reports portal. And the third is OCAN reports for organizations participating in the Mental Health Quality Indicator, or MHQI study. So we'll just go over a little bit more information about those 3 different types of reports. The software generated reports are two aspects of them. In your own software system, Ontario Health had provided specifications for software vendors to build reports into the software. And then there's some health service provider or HSPs that have developed reports and methods to do their own data analysis. And within the IAR generated reports, there are 4 standardized aggregate reports, and those are for OCANs that have been uploaded into the IAR. They're produced monthly and can be accessed by logging into a reports portal with an account, and the reports portal is called InfoView. This is a list of the reports, and as we go through the presentation, we'll be using some of these reports as examples. The left-hand side are the software generated reports using the Ontario Health specifications. And most of them, except for the workload report, the other three are reports on individual clients. And then on the right-hand side, these are the IAR reports, OCAN reports. And as you see, there's a 4A and B and a 6A and B. The A and B reports are actually identical in format. The difference is the A reports use the consumer or client self-assessment portion of the OCAN, and the B reports use the staff. The final source of data is that's available through reports for organizations participating in the MHQI study. And there are 17 organizations across the province that are participating. And the study has been undertaken by CMHA Toronto, CMHA Ontario, in partnership with Ontario Health and CAMH PSSP. The study has 3 main objectives: to pilot the development of performance indicators based on data available in OCAN, and supporting participating organizations to improve the quality of their data. And then the third is the benefit for all of us, that the study will be developing recommendations to inform enhancements to reports in the IAR reports portal that will be accessible to all organizations. So I want to take the opportunity to thank the research team as well as those 17 organizations, because this work is going to really feed into more enhancements to reports that would be available. The study approach that they have is they've undertaken a literature review of how Camberwell is used to measure outcomes. And then using the data from IAR, performance measures were created based on the research literature and feedback from organizations. And reports with these performance indicators were developed for participating organizations, and they're sent to organizations quarterly and semi-annually. And participating organizations provide feedback on the utility of the reports, strengths and weakness of the measures to refine the reports and increase the usefulness. And there is an article that CAMH wrote about the study. So this is a link here that you can access to read that article. So accessing the reports in these 3 different reports, of course, the first one, check your own system, or you could check with your OCAN, your software vendors about the reports, whether they've built those into the system. And the reports in InfoView, so those IAR reports portal, a lot of you I've sent in the last week some emails to help you create or reactivate accounts to be able to go in and access those reports. If you didn't receive an email or anybody has some questions about that, feel free to email me, and there's my email address. And then for the organizations participating in the study, Frank and his team will be aiming to send out reports to you, directly to you, for Q1, with Q1 and Q2 data before the February 2nd session. And the last here of the slide is the plug to, we hope that you bring your reports to February 2nd, or those reports that you find that you're able to access and that you find interesting, and to bring your questions about those reports. Now, for the rest of the session, we'll be talking about the OCAN data, the OCAN reports, and providing examples on how to use them at different levels, starting with and for clients. And this slide, there's 2 links in this slide, and organizations that want some guidance on how to use individual client content with clients in their practice. This resource was developed recently called Guidelines for Using OCAN Content in Practice, and there's a link right in there, as well as a link to a webinar session that was recorded. Here is an example of a software-generated report through the OOH specifications called the Needs Over Time report that you can use with clients to best answer the question, what are your needs and outcomes? And this was developed with sector input during the OCAN implementation based on the research finding that providing feedback to clients has a significant effect on improving mental health outcomes, and the effect is increased if feedback is given periodically rather than only once. Another key finding, which is intuitive, but there's lots of studies done around helping clients to convert their areas of unmet need to met need or no need, improves client outcomes. So how to use the report? Well, check your software, and if you don't have it in your software and have questions about it, you can connect with me. We can help you to get those specifications or link up with an organization that has this report. And this report can help focus client conversations on feedback and together look at the change over time for that client and to develop changes to the service plan based on what they're seeing in the report. And from a QI perspective, you can consider testing out the use of this report, maybe with a small group of staff and clients, as an opportunity to use OCAN reassessments in a meaningful way. There is a group of organizations that make up something called the OCAN Quality Improvement Network, and that network is looking at testing out this report. So let's take a look at this report. The nice thing about this report is that you can customize it for an individual client. So in the domains column here, you can select only those domains out of the 24 that is pertinent to the client. And then you can select the number of OCAN assessments that you want to include in this report. So if a client has 5, you can select the 3 most important or maybe the 3 most recent OCANs. In this illustration here, there are 3 different OCANs. The one on the left side is the earlier one, then going to the more recent ones. And you have the rating of both the consumer rating as well as the staff rating for each of the OCANs. If the staff rating was not, if the consumer decided not to complete the self-assessment, then that would be blank, but you would still have the staff ratings. And this can help you to guide conversations about areas of progress for a client, new unmet needs that come up, persistent unmet needs, looking for new or different strategies to maybe better address what you're seeing as a recurring unmet need, and having conversations that share different perspectives between client and staff. So just here in this illustration with company, you'll see clearly that unmet need over time has been converted to met need and no need, showing progress and validating client strengths. And then what's important to note is that the evidence shows that the reverse is not the same. So changing from a no need to an unmet need does not necessarily mean decline. You have to have conversation with the clients to understand the context. So for example, in daytime activities, an illustration could be that initially the client was really struggling with symptoms of psychological distress, and daytime activities really wasn't on their radar. They were content being at home, playing video games, for instance. And then over time, as their symptoms and psychological distress become addressed and improved, they identified feeling lonely and bored and wanting a change, and then identifying that as a new unmet need to work on. And that is actually significant, indicative of progress. So now moving on to OCAN data with and for staff. And this is another plug about this guideline that we have about using OCAN content in practice. It's the same guideline, but there's a section on how you can use OCAN content to help structure supervision and team meetings with staff to help guide decisions around service plans. So just to show you where that section is. And then the example that we're going to use for at the report to use with staff is one of the OCAN IAR reports called the Needs Analysis Report. And this can answer a series of questions, help to answer what services are people using, what care needs do people we serve have, and does this report reflect your day-to-day support of clients? So let's take a look at the report. These are available in the IAR reports portal. And as you could see here, what I've shown in the box in the middle is this report. It's available monthly, but it's a rolling annual. It reflects 1 year of your client's needs analysis. So in this example, it's from 2019-2020. There are 166 OCANs included in this report, and this is the most recent OCAN of the clients that have been active in your service for that year. So if a client has had 2 OCANs done in that year, it picks up the most recent one. So it's a most recent picture of your client population in their needs. And it is also broken down by functional center. So in this case, you see here that is case management, and that is for this sample, this report, 165. So almost the total amount of assessments are reflected in case management here. And this shows you from greatest to lowest combination of two ratings, unmet need and met need. Unmet need here, let's look at psychological distress. 52 out of 165 clients have psychological distress as an unmet need, which is 31%. And then with met need, 89 out of 165 have rated this as a met need, and that's 53%. This is also reflected, the same data in a bar graph, with red being unmet need, green being met need, and then the total percentage of the combination is 85. And the idea here of using both of those ratings is because unmet need is that's a significant problem to focus services on. Met need means that that area is being managed. It's because they're receiving support. And if that support were taken away, it could become a serious problem. So for this case management program, psychological distress, daytime activities, physical health, and company are the areas to really focus services on and QI work on. So let's just talk a little bit here about how you can discuss this with staff. So you can talk about, is this reflective of the work that you're doing with clients? You can also look at validating the hard work of the staff in helping to meet client needs. So for example, pointing out that 53% of clients experiencing psychological distress are receiving positive, helpful support. You can also look at it from discussions on innovative ways to better support client needs, focusing on some of those domains that are showing higher unmet needs. So for example, benefits, are clients getting the benefits that they're entitled to? That would be a way to talk about that piece of how to explore improving that area. And then maybe also how your staff can engage in advocacy activities related to, for example, accommodation at 41% high unmet need. So I'm going to just quickly illustrate an example of an organization that used this needs analysis report. And what they did is they used it to guide some team practice development. And they had weekly meetings, and they had their whole team attend. And each meeting they focused on one of the domains, starting with the domain of greatest need. And they asked their staff to bring their list of clients that had that particular domain as an unmet need. And they had conversations to understand the common themes around the client's situations, experiences, and context. And from there, they started to develop and just determine some new innovative evidence-based ways to address some of those needs. And here's some examples: company and intimate relationship, so cognitive behavioral social skills training group, psychological distress using dialectical behavior therapy. And then with unmet need activities, a common interest was gardening, and to start a gardening group with daytime activities. And then in the area of physical health need, they developed a business case to support the addition of a nurse practitioner. And last but not least, with the staff piece, is another thing that you can do with the OCAN data. And here's an illustration of looking at the need domains and creating a menu of services that would best address those areas of unmet need for clients, both within their organization, for instance, CMHA Toronto, and the various programs, but then also with some of their partner organizations, for instance, across boundaries. So it can help with care pathways and to make decisions developing this kind of menu, and it could be used, for instance, with Ontario Health Teams. I will now pass it over. I'm going to give up the control and pass the deck over to Frank Sirotich to give examples of the reports and data at the other levels. Thanks, Frank.
That's great. Thank you, Jennifer. Great. Got it. Thank you. And good afternoon, everyone. Okay, so just to begin with, building off what Jennifer had talked about, The data in the OCAN, in addition to being used directly with clients and with staff, can be used at an organizational level. And it can be used, for example, to help us begin to answer the question of who we're serving. So there's the potential to create reports in some client management systems, and we can pull certain characteristics or data elements out of the OCAN that might be helpful. So an example is pulling out demographic data, such as what you see here. Now, this is a high-level report, and the OCAN obviously has a more granularity in terms of different categories. So, for example, the racialized community, it actually breaks it down by different groups. Gender identity, there's obviously many more categories, and similarly in terms of sexual orientation. How this can be helpful, in addition to giving us an idea of who we're serving, we can pair this data with other community data like census data, or even OHT, attributable population data, really to see how similar or different clients that we are serving are from the broader community. And that begins to provide a health equity lens to see, are there any potential issues with respect to equity of access? The OCAN, we can also look at clinical characteristics of individuals, specifically diagnoses. And this could be really helpful in terms of understanding how diagnoses or clinical characteristics relate to the prevalence of specific needs, and also longer term our outcomes. So as a concrete example, is the prevalence of anxiety and mood disorders related to the prevalence of unmet needs related to psychological distress, or prevalence of psychotic disorders related to the prevalence of needs related to psychotic symptoms, concurrent disorder, alcohol and drug use, or chronic physical health conditions, physical health needs. The OCAN also tells us whether or not a person's attached to a physician, a psychiatrist, and also provides information on self-reported ED use. Now, attachment to primary care, to psychiatry, and repeated use of emergency department can all be thought of as proxy measures of service integration across sectors. So that also is useful information for planning purposes. If in some instances, organizations have decision support capacity, they can create their own reports, and that was just an example of a potential report that you could create. Again, when you're looking at an equity lens, you would want to drill down. This is high level, but if you wanted to compare individuals in your organization to the community, more granularity in terms of specific data elements would be helpful to do better matching. Organizations that are participating in the OCAN study would receive this information through a report. This is report number 1, and essentially what you're seeing here in this graph is report is very similar to the graph on the previous page. The key difference being there's a provincial comparator. So here the green bar represents the prevalence of characteristic for clients in the case management in one organization, and the orange bar represents the prevalence across all clients in the province. And again, this can help contextualize your service outcomes when you start to compare yourself to the province. Data in the OCAN can also help us get a picture of individuals' needs. And so in some instances, software generated reports could be created to identify the prevalence of unmet needs. So here in this graph, what we're seeing is each of the bars represents a different need domain, and it gives the indication of the degree of prevalence of unmet needs. Now, this information could be helpful really for a few things: for program planning, to also advocacy in terms of an investment in particular services, and to help identify areas for quality improvement. What that might look like. So these data are for all clients enrolled in case management services that have an OCAN uploaded to the IRR in fiscal year 2020. But if this was an organization's data, the organization can see, okay, what are the needs that are most prevalent? And what I think is most noteworthy here is that the needs that are most prevalent are needs that may require a multidisciplinary approach and may actually fall outside of the core competencies of most case managers. And that case managers, to address these needs, might be referring individuals out to other services. So from a planning perspective, organizations can see, okay, based on the prevalence of these, do we have other programs in our portfolio of services that we can integrate with our case management services or create pathways to better address these needs? Or they could go outside of their organization, especially in an OHT context. Are there other providers that have services that would help us address these needs. So for example, for psychological distress, that might be counseling and therapy services. For daytime activities, that might be supported employment or some kind of structured daytime program. For physical health, primary care. For company, it might be a social rec program, or it might be even peer support. Organizations could also look at, within their case management team, do they have the appropriate service mix given the prevalence of particular needs? And if they don't, is there a possibility to reallocate resources, or for example, to convert a case management role into a counselor therapist role to better address the needs? To the extent that services aren't available either in the community or within the organization, and it's not feasible to reallocate resources, then organizations can use this data to basically advocate with their funder an expansion on services that would be most relevant to addressing needs. And then finally, if services do exist, but we're finding that over time it's the same needs that are coming up and they're prevalent, it begs the question, is there something else that we could be doing? Could we implement an evidence-based approach to address some of the needs? Or conversely, are there some kind of barriers in access to services that we already have that are preventing individuals from accessing these services? So organizations that are participating in the OCAN study would have access to a report that would give information about the need profiles of individuals. So this is an example report number 3. And if we look under the accommodation domain, what you can see is it provides a breakdown for your particular organization, a count of the number of individuals that have unmet, met, no need, and unknown, and then a percentage breakdown, and then finally a provincial comparator, how your clients compare to clients across the province. Excuse me, in this particular instance, what we're seeing is there's not much difference. There are very comparable rates of unmet need between the organization and the province. A similar report is available in the IAR, and Jennifer actually just spoke about this report previously. And in this report, as you can see, it provides you information about unmet, met, and the combination of both unmet and met need. So we can look at what are the most common combination of met or unmet needs. Here we see the top 4, and on the far right, that's the combination percentage of met and unmet need. Now, this is, I think, particularly useful, both the unmet needs and any needs. And I think they tell us different things. So we can look at the unmet needs where it appears as areas of service gaps or areas of priority in terms of providing support to clients. But we can also consider any needs, or the combination of unmet and met need. And that is more, I think, a description of the characteristics, in this instance, the needs of individuals. So irrespective of whether or not individuals are attached to services, if they have any need, they'll likely need support in that area, whether we're providing it or another provider is providing it. And then from a planning perspective, we can have that in mind. These are essentially need characteristics of individuals. Do we have the appropriate service mix to best address these needs? The OCAN data can also help us identify service outcomes. And there are reports available through the OCAN study as well as the IAR. So through the OCAN study, this is report number 5. Now, there's been some modifications for those organizations that have been participating. We've tried to simplify the report based on your feedback, and I'm just going to walk you through. You have this data, but in a slightly different format. So in just walking you through, this assessment is based on the 2 most recent assessments. So let's call those the previous assessment and then the most recent assessment. And we're looking at really change over time. So if we look at accommodation, what we see is on the prior assessment, or the first of the 2 assessments, that's the count of the number of individuals that have an unmet need for accommodation. Then in the next set of columns, that provides us with a count of the number of individuals in their most recent assessment of the 73. So of the 73 in the previous assessment who had an unmet need, now 44 still have an unmet need, but then 11 have their needs met, and additional 18 have no need. And then you have the breakdown by percentage. So in this instance, we see a 40% positive impact or change between the two assessments. And then with the IR, we see a similar information, but slightly different format. So for accommodations, we can see in their previous assessment, or the first of the 2 assessments, 22 individuals had an unmet need. And then subsequently, of those 22, 10 still had remaining unmet needs, but 9 now have no need, and 3 have a met need. So in total, there's a 55% positive impact. How you could use this data is you could select a particular need domain for an area of focus and then develop a run chart or a trend chart over time. And what you see, here's an illustration of that. So each along the x-axis, those would be different Q1, the quarter 1, quarter 2. And then the percentages are the percentage of remaining unmet need that we'd be seeing essentially at time 2. So if your focus was daytime activities, you might develop some change activities. Let's say you've converted a case management position to a supported employment worker who's now embedded in the case management team. And you want to know, is that actually impacting, reducing unmet needs? Well, you can track that over time to see, is that having an impact in terms of the remaining unmet needs for daytime activities. And then the OCAN data can also have applications at a regional level, including OHTs. So one way that we can do this, in terms of the reports that you're receiving, you can consolidate those reports into a master report. So using the aggregate data within those reports, you can aggregate them even further to represent a network of providers, to begin to see what there are similarities in terms of what are the characteristics for clients that are similar and different across organizations. Are there potential areas where there are common unmet needs across all, for clients across all organizations, which might speak to service gaps? And that in turn can help identify opportunities for collaborative quality improvement initiatives. You can also use some of the reports like I just spoke about, report 5 in the OCAN and report 6 in the IAR. You can aggregate those and look at any collective change ideas. Is that having a collective impact with respect to clients? And then finally, you could also use, if there are differences across organizations, that can also be very useful for quality improvement purposes. So for example, if an organization is performing particularly well in addressing a need domain, we can explore what is that organization doing and is it transferable or could it be adapted in other organizations in the OHT? And then scale essentially that approach. So we're essentially promoting service excellence collectively by sharing that information. In addition to consolidating reports, there's additional measures that we could consider. So you could, if you have the capacity within your software, generate reports. And one of the things that you could potentially look at is, are there continued unmet needs over time, which is really a form of service outcome. And by that, we refer to that as persistent unmet need. And we define that as where there's at least one need domain, where that need domain, the need remains unmet consistently over 3 consecutive OCAN cycles. So over 3 assessment cycles, let's say psychological distress, the same client would have unmet need across 3 consecutive assessment cycles. Where that would be helpful really is to identify gaps in services. And with that knowledge, especially in a network of providers, you can start to have conversations about, are there opportunities given the continuum of services that you have available across all the partners jointly to create prioritized pathways for clients to best address the needs. So in short, it helps identify opportunities for collaborative quality improvement. And then you can also use this over time to monitor performance. Is it having an impact? So concretely, what that could look like, we actually use these data in OHT to help inform a collaborative QIP. So what we found was, in terms of psychological distress, some of the change ideas that we developed, 2 of the organizations converted case management positions into counselor therapist positions to better address that need. And then for daytime activities and company, we formalized pathways across organizations to social rec programming, to peer support, and to employment program. And this all with the intent of trying to increase flow. By that, I mean trying to address needs more timely with clients to facilitate throughput, because what we're finding was after COVID, our wait lists had really ballooned. For organizations that are participating in the OCAN study, they would receive report number 6. You've already received a version of this with a different format. In terms of the format, it's essentially the same thing that we're seeing in the previous slide, the key difference being it includes a provincial comparator. And then we can also use the provincial or the data at a provincial level. So some of the reports we can use the same reports in terms of describing the population and their needs, but we can also create a metric for outcomes. And one of them is the Met Need Index. That's drawn from the research literature. And what it is, it's a ratio. Essentially, the numerator is the number of positive outcomes. The denominator is the number of both positive and negative outcomes. And that gives us a ratio between 0 and 1. The closer the ratio is to 1, the better the outcomes. And this can be really advantageous for a number of reasons. It is versatile, so that Met Need Index score, we can apply it to an individual need domain, to clusters of needs, or to all 24 need domains with one score. It's also versatile, so one score can be applied across multiple assessments. So if a client, for example, had 4 assessments, with one score, we can describe the impact of services across all 4 assessments. It's intuitive. If we multiply it by 100, we actually get a percentage. So if we have a Met Need Index score of 0.60, that's telling us that 60% of outcomes were positive. There's a positive change, and it's comprehensive. So it looks at not only change between an unmet and a met need, but between a met and no need in terms of change, as well as from unknown to no need or a met need. Sorry, this doesn't seem to be, there we go. So this is an illustration. Each of the bars represents the Met Need Index for a particular need domain. And this is for individuals enrolled in case management services that have 2 or more assessments. It also provides us with a summary score, which is the total of all these 24 need domains. That 0.68 means 68% of the time there are positive outcomes. And then we can also drill down to see what's driving that score. So we see with accommodations, for example, that has a Met Need Index score of 0.84, so 84% of positive outcomes, whereas sexual expression has a Met Need Index of 0.19. Just a word of caution though, these measures are developmental. We shouldn't be drawing inferences about the performance of the sector at this time because not all organizations are uploading the OCAN, and in addition, there's missing data. So we had to exclude some cases because of missing data, but we're working with organizations to help them improve their data quality. How this could potentially be used with an equity lens, we can take the summary score for different groups and see if there are differences. So for example, if we look at sexual orientation, we can see that individuals from the LGBT community had somewhat lower rates of needs met compared to individuals that identify as heterosexual. But when we factor in the confidence intervals, it might be relatively comparable. Organizations participating in this study would receive report number 8, which would cover some of this information. So the report number 8 would provide you with the Met Need Index score for the province, then for your organization, and it converts that into the percentage of positive outcomes, which you see here, and then the clients that were used to calculate that index. The color coding also is an additional benchmark. So red means the organization performed in 40th percentile or below for that particular needs or area of potential focus, whereas the green is in the top 75% or an area of service excellence. And this could be used to, again, to help identify areas for focus for QI. And you can use this over time in a run chart, much like that we identified before. You can track change ideas to see if there's positive impact. The way that you would do that, you could start by looking at where there's red highlight, but what I'd encourage you to do is to look at the counts as well. So you can see for childcare, it has the lowest Met Need Index score, but it only relates to 15 individuals, whereas daytime activities involves many more clients. So with limited resources, that might be a factor in what areas you focus in on. And then finally, just to summarize, 2 key questions that we wanted to address is what's the OCAN and the why, and hopefully you have a picture of how to use it, although there'll be more details to come. In terms of what the OCAN is, it's a tool that helps us answer key questions, and these are important for a variety of reasons. The key questions it helps us answer is, who are we serving? And that provides context for understanding the needs and outcomes of clients, as well as helping identify potential inequities in access. It helps us answer, what are the needs of clients? And that can be helpful to identify matching clients to the appropriate services, helping for planning purposes in terms of either creating new programs or modifying them. And similarly, either within an organization or within the context of other partner organizations in an OHT, it helps us identify what the service outcomes are. That helps us measure performance, inform quality improvement, drive service innovation and service excellence. And then finally, it helps us identify, are there differences across groups, which helps us identify disparities and begin to address any potential service inequities. And with that, I think I am turning over to Ian and Laura. Thank you.
That's great. Thank you so much, Frank. Thank you, Jennifer. I have been collecting the questions in the chat box as we have been moving along. And we will have hopefully a couple of minutes to answer some of those questions, but we will not be able to get to all of them. So please keep typing them into the chat box. We will be collecting them and preparing answers for you and sending those back to you either through the webinar, or sorry, the workshop on February the 2nd, or through that question and answer sheet that Ian referenced earlier. On the next slide, we have a request of the participants. As we are typing in our questions into the chat box, if you could provide some feedback to us on this webinar today, we'll launch the poll and ask that you answer some questions for us. We will then move into the question and answer section of this webinar with some follow-up information to share with you. We'll just give you a few minutes to answer the questions, to scroll through. We have 7 questions in total with a Likert scale to choose from. And as a reminder, we will have a recording of this webinar to share with all participants who registered. And if there are those in your organization who were not able to attend the webinar and did register, they will receive a link to the webinar that they can view in advance of the workshop on the 2nd. Thank you. I see that the polling results are coming in. I really appreciate that information. In true QI fashion, we do look at every one of these responses and make adjustments as we continue to deliver on these webinars and workshop series in the data literacy series. Just give it a few more minutes and then we can move on to the next slide. That's great. They're still coming in. As you know, without good data, we can't make any changes. So really appreciate the intention of completing this evaluation poll for us. Great. I guess based on the kind of like the popcorn in the microwave. It's like we got one more response coming in and last pop, and then I think we can close the poll. Okay. Thanks, Naveen. Yes, if we can just keep that poll open, that would be lovely. So we can move on to the next slide. And this is where we will start answering some of the questions that have come up. So at the very beginning, Jennifer, somebody asked in the session, are mental health organizations required to do the workshop? And I had responded in the chat box that it's not a requirement and that the workshop wouldn't be recorded. So there wouldn't be that follow-up. But then there was a question around, is there a difference between CRMS and IAR for uploading the OCAN?
Okay, good question. And just on that first one, Laura, I would say that for sure it's not a requirement, but if anyone wants to have one-on-one conversations about this information, feel free. We have our email addresses in this deck and you can feel free to reach out. Difference between CRMS. So yes, this CRMS is one vendor. So the approach that, whereas IAR, any there's various software systems out there that are organization software. CRMS is one of them. But then what happens, it's a multi-vendor approach where the idea is there's, I think, about 16 different vendors in the community mental health sector, CRMS being one of them that's built into your system. But what we did with these vendors like CRMS is develop specifications to ensure that once an OCAN is completed in your system, it can successfully be uploaded to this one central repository called the IAR. So a copy, essentially, of the assessment goes into this one central repository from various vendors like CRMS. EMHware is another one, Treat is another one. So I hope that answers the question.
That's great, thanks. Jennifer. Frank, one of the questions that came up at the beginning of your presentation, there was a couple of folks that were asking about the statistics and the data that you were presenting. Is it real data or fictional? And that was related to the slide. The first one was related to the slide that around the most recent assessment in intensive case management for the fiscal year 2020.
No, so that is, that's actual data. Everything that was presented was actual data, either at the provincial level. So that particular slide was for all individuals enrolled in case management that had an OCAN uploaded during that fiscal year, and we used the most recent assessment.
Great, and then not sure if you noticed the question related to the aggregated data. Is there a link between this data and two provincial priorities, including funding, back office support and programs? Mental health and addiction has always been underfunded.
That's a good question. That's really a policy question, I think, for a funder. My understanding is they're part of the plan for the province is, and they're rolling this out in phases in terms of standardized data. So we're starting with the provincial data set, which is more socio-demographic and social determinants of health, as well as where people are enrolled in services. But the intent is over time to include some kind of assessment data, whether that's the OCAN or something else. I think that's yet to be determined. But my understanding is that the intent is for a data strategy for the provinces. They're doing that in phases, and that would be a priority. And that, so starting with, really, you can almost think of them in terms of the questions that we're answering. Who are we serving and what services? And then once we have the data collecting there, what are people's outcomes? And then are there disparities across groups? So that second phase, that's a priority, but what the tool is, I couldn't speak to that. Jennifer, I'm not sure. I don't want to put you on the spot. I'm not sure if you have any...
No, that's fine. Just a couple of things to add to that point. Yeah, you're absolutely right, Frank. We're not there yet in terms of the phases, but that is being looked at. And what our team and the Standardized Community Assessment team in Ontario Health is working with the Centre of Excellence at Ontario Health. One of the big pieces of work that we're actively involved in is full alignment between that first phase of what Frank had commented on, the PDS that contains socio-demographic information and service use information that is very much the same, but not quite exactly the same, some of the fields, as OCAN. So we're working, the goal is to have full alignment, so reducing duplication of entering that so that it can get populated, the PDS, into OCAN for those fields. When it comes to the outcome data, which is sort of the needs over time and the Met Need Index being one potential outcome, that is being discussed at this time.
That's great. Thank you very much for answering those couple of questions. A bit of a teaser, I suppose. And I just wanted to move towards I believe I controlled the next slide. Just wanted to make sure folks had what they needed to attend part 2, which you've already registered for Thursday, February the 2nd, and it's a 2-hour workshop. And the intention of that workshop is to help organizations answer any questions specific to their own reports related to the OCAN and the IAR. And if you could reach out to Jennifer, who has graciously offered her support to make sure that you are able to connect in to those reports in advance. And for those who are part of the MHQI study, you can also bring your reports to the workshop, and if you need support, to please reach out to Frank. And you should have all of the information related to that workshop already in your inbox. If you have any questions, please reach out to us at E-QIP. We're happy to help.
And Laura, can I just
yes,
interject
please.
one point is that I wouldn't necessarily deter you if you don't have those reports. Let's say you haven't been uploading to the IAR, but you're interested in this content, then feel free to come to the February 2nd without the reports and sort of listen to those that have the reports and have questions about it. So, you know, you're welcome. If you can't get your hands on the report, you can still participate.
That's great. Thank you. And I am clicking the locus. So the level of care utilization tool, the system, the locus level of care utilization system is a tool that we are going to be highlighting next. That starts February the 9th. And we have a webinar that day and then a workshop on the 23rd. Please stay tuned for registration links. Those are coming soon. And again, a huge thank you to Frank and Jennifer for their time and sharing their wisdom with us all today, and to all of you for attending. We look forward to seeing you the